who have joined this evening for this very interesting and exciting program on primary hyperaldosteronism. This is a series of series of webinars that we have been conducting called Adrenal Medicine, where we are focusing on different aspects of adrenal disorders. And we are thankful to Samarth Pharma for sponsoring this series. And we had a series of six webinars last year also, and this year this is the third in the series this year. So this is a very interesting program that we have today. We are discussing about primary hyperaldosteronism, which over the years we have recognized that this is becoming an important cause of secondary hypertension, or rather, 5 to 10% of all hypertensive patients tend to have primary hyperaldosteronism, and this is one of the important causes of resistant hypertension also. So it's important nowadays. It's being increasingly recognized that this is a problem that has to be screened for in most of our hypertensive patients, if not all. And so for this, we have a very interesting session lined up today. We have a presentation, and then we have panel discussion. We have a very eminent international endocrinologist along with us, Dr. Ved Gosain. He'll be introduced to you by my co-moderator, Dr. Saptarshi Bhattacharya. I request him to introduce the panel.
A very, very warm welcome to all the speakers and panelists who have joined, and also to all the delegates who have taken out time to attend this meeting on a very, very important topic, primary hyperaldosteronism. As Dr. Rakesh told, that this remains an underdiagnosed problem, and we need to be more and more aware about when to screen for it, how to investigate it, how to manage it, and how to follow it up. So we have a very eminent panel today. I first invite, I will be first introducing our speaker today. She is a very young and dynamic endocrinologist, Dr. Sara Alam. She did her DM in endocrinology from All India Institute of Medical Sciences, and now she is currently practicing as a consultant in Asian Institute of Medical Sciences, Faridabad. She has numerous gold medals, so 8 or 9, it's very difficult to count. Then she received the first prize in oral presentation in Endocrine Week 2020, and as well as in Trendo 2020. She also has won many quiz prizes, multiple publications, and member of the major endocrine societies of India and USA. So her research interests are young diabetes mellitus and primary hyperaldosteronism. I also have the pleasure and privilege of introducing Professor Rakesh Sahai. He was the Vice President of Endocrine Society of India, and also the Vice President of South Asian Federation of Endocrine Societies, or CEFES. He is also the President-elect of Endocrine Society of India, so he is going to take over that position next year. So we are all eagerly waiting for that. And he has been like multiple achievements, vice president of multiple major organizations, and former secretary of Endocrine Society of India, is the founder secretary of CEFES, multiple awards, multiple publications. So a very reputed and eminent national and international endocrinologist. We are really honored to have him in for this meeting. Then I have the proud privilege of introducing Dr. Ved Gosain. He is MD, FRCP, MACP, FACE, is the Emeritus Schwartz Professor of Medicine and former Chief of the Division of Endocrinology and Metabolism at Michigan State University. He served as the Chief of Division of Endocrinology from 1996 to 2015 at MSU. He also established the Endocrinology Fellowship Program at MSU and served as the program director since its inception in 2006 to almost for next 7 to 8 years. So he has multiple publications, multiple awards, including the Presidential Citation Laureate Award, Professor Viswanathan Oration Award. So it's a very, very prestigious moment for us that we have a international reputed endocrinologist of his stature. Very warm welcome, sir. We are keen to hear from you on this topic. We also have another very young and dynamic endocrinologist, Dr. Rajat Gupta. He happened to be my colleague during my residency days, and All India Institute of Medical Sciences, and he's a very good friend of mine also. He's a senior consultant endocrinology at Alchemist Hospital, Panchkula. Multiple publications in international and national peer-reviewed journals, many chapters to his credit in endocrine textbook, multiple orations he has already given, and he received the prestigious A.V. Gandhi Award for Best Methodology in Research Work on Vitamin D. A very warm welcome, Dr. Rajat.
Finally, I would like to introduce the co-moderator to this session, Dr. Saptarshi Bhattacharya. You have been hearing him. He is a very eminent endocrinologist from the city of Delhi. He has done his DM in endocrinology from the prestigious All India Institute of Medical Sciences. He is currently the senior consultant and head of the division of endocrinology and diabetes at Max Pratapganj in New Delhi. He is the director of e-health diabetes and endocrinology center at Noida. He is member of the American Association of Clinical Endocrinologists. He's been a very active member of the Endocrine Society of India, and also he's played a very active role in the Indian Society of Bone Mineral Research and the ISPE also. He has also authored several articles and chapters in textbooks, and he has been a very active member in the Endocrine Society of India. So I have pleasure in having me as in moderating this, having him moderating this session. So we now would like to not waste more time on the introductions and go on to the topic of the day, and we would like to invite Dr. Sara Alam to give a presentation on this, and then we'll have the panel discussion. Dr. Sara.
Thank you, sir. It's an absolute honor and my great privilege to be invited as a speaker in this prestigious forum. I'm really thankful to Dr. Saptarshi and Dr. Rakesh Sai, sir. Please allow screen sharing. I think.
The host.
Please allow. Please allow screen sharing.
Mr. Bajaj, please.
Yes, ma'am.
Please.
Yes, yes.
Now you have allowed. Be a very good evening to everyone. So the topic for today is primary hyperaldosteronism, screening, diagnosis, and management.
The screen share is showing your downloads. It's not showing. So you'll have to stop share and share the presentation.
Okay. Is it visible now?
You can.
Is it visible now?
Not now. No. It's not yet. You can open first slide first. Yes,
Yeah.
Is it visible?
I have to sharing. Yeah.
Yes.
Is it visible now?
Yes, ma'am. Yes, it is visible now.
Okay. So the topic for today is primary hyperaldosteronism, screening, diagnosis, and management. Let me begin with a case first. This is one of our patients, 61-year male, apparently well 14 years back, age at that time 47 years, when he was found to have hypertension on routine testing. He was started on telmisartan 20 milligram and doses were gradually increased. He took only telmisartan 40 milligram once a day for 12 years and blood pressure remained around 140/90. 3 years back, he had an episode of sudden onset breathlessness, chest heaviness. Blood pressure at that time was 210/110 and potassium of 1.6. However, he did not follow up after discharge from emergency. 2 years back, again he had an episode of severe headache, came to emergency. Again, his blood pressure was found to be extremely high, 238 by 110. He was given injection labetalol and tablet amlodipine. At that time, sodium potassium report is not available. He was again discharged on 2 antihypertensives and full workup not done. A similar story of patient 2, a 52-year-old female, apparently well 13 years back, age 43 years at that time. She was found to have hypertension on evaluation for headache, initial blood pressure 190 by 100. She was started on unknown antihypertensives and doses gradually increased. Initially, blood pressure controlled on 2 antihypertensive. 4 years back, she had a fainting episode and headache. She was taken to a hospital and blood pressure was 230 by 130. She was given antihypertensives and asked to come for follow-up. Now, she used to have these episodes of episodic hypertension, headache, and where she had to go to emergency. Her antihypertensives were continuously up titrated. However, there was no effort to uh, do diagnosis and the cause of these episodes was made. There was no documented hypokalemia in this patient. So what would be the next step in such patients? There are 5 options. I'll come to these afterwards. So first option is normalize serum potassium and test aldosterone-renin ratio, obtain computed tomography scan, prescribe spironolactone, screen for diuretic use if hypokalemia is there, or get plasma metanephrines and normetanephrines. Now, just a very quick revision of basic physiology. This is the schematic of adrenal gland and the biosynthetic pathways of aldosterone and cortisol formation. It's a common pathway of cortisol and aldosterone secretion, and the final step of secretion, it occurs in zona glomerulosa. Uh, Again, it's showing aldosterone signaling, and this angiotensinogen forms angiotensin 1, then angiotensin 2, which stimulates aldosterone secretion, causes sodium chloride reabsorption, potassium secretion, and water retention. Arterial stiffness, hypertension, and cardiac remodeling also occurs. As we know that it's not just about the blood pressure. Aldosterone has multiple pleiotropic actions contributing to the pathogenesis of cardiovascular disease. It can cause inflammation, vascular endothelial dysfunction, cardiac fibrosis. Hypertension obviously is there. It causes dyslipidemia, dysglycemia, increases gluconeogenesis, renal sodium potassium dysregulation. So it's multiple pleiotropic effects. So it's not just about controlling the blood pressures. We need to make a specific diagnosis and target. So, scope of the problem. Primary aldosteronism remains profoundly underdiagnosed worldwide. Hypertension is an important public health challenge, contributes to the global burden of cardiovascular disease, stroke, and premature mortality. In majority of patients, hypertension is primary. However, a subgroup may have a secondary cause. It is especially significant in younger patients less than 40 years old. Recently done Great India BP survey by AIMS had shown a high prevalence of hypertension among Indian adults, 30%, and in prevalence in 18 to 39-year-old. In those patients coming to our clinics, we many times even blood pressure is not checked, thinking that, okay, this is a young patient. But in those patients, prevalence of hypertension found to be 19%. Primary aldosteronism, at least minimum prevalence recognized 5 to 10%. So approximately 1.3 billion people globally suffer from hypertension. So if we calculate 10% of that, it comes out to be a huge figure. Any conservative estimate is used. Total number of people having primary aldosteronism would be extremely large, undiagnosed. And there is paucity of data on the prevalence of PA, especially in the developing world. So the question, who should be screened? These algorithm are from the Dr. Williams Young group, from Williams textbook of endocrinology, Dr. Young group, Mayo Clinic. So in the 2016 edition, they have said that, this is from the guideline also, that hypertension and hypokalemia patient, resistant hypertension patient, adrenal incidentuloma patient, severe hypertension patients, these patients should be screened. In the newer edition, they have focused that all patients with hypertension should be tested. This is the ideal scenario. Ideally, once in a lifetime, every patient should be screened. Although cost effectiveness, that has to be discussed, but it's too big a thing to be missing primary aldosteronism for life, given its morbidity. Now, how should we screen? Previously, they have said that a must of aldosterone concentration more than 15, that is a must. However, now the limit is being lowered because it's not like an absolute value. It's primary aldosteronism is also a spectrum, and patients could have primary aldosteronism with even lower plasma aldosterone concentration. So, in the latest edition, they have decreased this value to 10. Instead of ratio, it is better to focus on individual aldosterone and renin concentration. So why should we screen? As I've already told, patients with primary aldosteronism, substantially higher risk profile, 4 times increases for stroke, 6 times for non-fatal MI, 12 times for atrial fibrillation, then age match, sex match, and blood pressure match people with essential hypertension. And patients with primary aldosteronism, and incidentally patients with resistant hypertension and so-called even low renin hypertension, even when the aldosterone levels are not reaching that cutoff of 10 or 15, MR antagonists can be game changers. So treatment with conventional hypertensive drugs alone is clearly inferior. So it's not just a matter of lowering blood pressure, it's a matter of nullifying the excess effects of aldosterone on sodium status. There is a poor screening rate worldwide, despite the large number of studies indicating the prevalence of primary aldosteronism is high, around 10%, yet, and this disorder can be treated to modify cardiovascular risk. This information has not yet translated to higher screening rate. Even in high risk groups where the prevalence of PA can be around even 50%, less than 3% of patients are screened. Data from US, Italy, Germany, Canada. So this study, interesting study, published in Hypertension 2020 by Jaff et al. And this data is, this is from USA. Retrospective cohort, 1,45,670 patients with hypertension, 3.7% had resistant hypertension. So of these patients who were diagnosed with resistant hypertension, see, let alone we talk about screening every patient with hypertension. Now, resistant hypertension is a group which clearly needs screening for primary aldosteronism, and in that group, only 2.1% patients were screened for primary aldosteronism in USA. We don't even have any data from India regarding that, so the rates can be expected to be worse. This data is from Canada. In this, of the 1.1 million adults with hypertension, 0.7% was screened for PA. And let alone, screening is one thing. Proper, even after screening, patients are not managed properly according to proper diagnostic algorithm. So less than 1% of patients expected to have primary aldosteronism were ever formally diagnosed and treated. This is our study, and this is the first data from India using screening and confirmatory test and endocrine society guidelines. And we have shown in young patients prevalence of primary aldosteronism by age of, it was found to be 18.8% screening positive, and primary aldosteronism was confirmed in 17.8% in young patients with age of onset of hypertension less than 40%, less than 40. Prevalence of primary aldosteronism increased with grade of hypertension, number of antihypertensive medications, and severity of hypokalemia. So we have a high percentage reaching close to 20% in young patients. It is really significant, and although our sample could be said to be biased because we had referred patients, still it is significant. Larger studies are definitely needed given such a high prevalence of hypertension. So why don't we screen enough? What is the reason? One cause is that lack of education provided to primary care providers and frontline general clinicians. There is less awareness. And second and concomitant problem is that the complex diagnostic algorithm requiring several hospital visits and the need to withdraw interfering medications, which may be difficult. Also, the legacy memory of being thought that primary aldosteronism is a rare and relatively benign condition, but it is neither rare nor benign. So a very important question, as I advocate to screen every patient. That may not be possible given the cost constraint. However, this study published in Circulation 2015, they have used a decision analytic model, compares aggregate cost and systolic blood pressure changes. And they have found that CT scanning followed by adrenal venous sampling was a cost-effective strategy to screen for primary aldosteronism. Also, availability of adrenal venous sampling. That is also an issue, that it is not available at most of the centers in India at present. So coming to the classification, aldosterone producing adenoma is 30%, bilateral idiopathic hyperplasia 60%. Then we can have the other rarer varieties, aldosterone producing ACC and familial hyperaldosteronism. Now, this is from Endocrine Society 2016 guideline. So they have recommended aldosterone-renin ratio as the screening test. In case in which hypokalemia is there, renin is below the level of detection, and plasma aldosterone concentration more than 20, in such cases, confirmatory test can be skipped. So in overt cases where the patient is having a spontaneous hypokalemia with suppressed renin, in that it can just be a waste of time and also resources to do confirmatory test. In such patients, we can skip and directly go to second step, that is adrenal CT. And even adrenal venous sampling step can be skipped if the patient is young age. They have used 35 as cutoff for young, and the patient is having marked primary aldosteronism. Then if clearly more than 1 centimeter adenoma is there, we can treat with laparoscopic adenectomy. Or if it comes out to be bilateral, then we have to treat with the mineralocorticoid receptor antagonist. Now coming to one of the difficult things in interpreting aldosterone-renin ratio is the effect of drugs. We know that the patients who come to us with hypertension, they are already getting multiple drugs. Then how to go about that? So we can see that most of the drugs, they decrease aldosterone or they cause false negative ratio. So if we continue the medications and despite that a patient is having positive screen, so that is significant. It is very important to remember that, because we can interpret the results if we know that how this particular medicine will affect the aldosterone-renin ratio. So in terms of that, we can interpret despite the patient continuing the medications, because in most of our patients, it might not be possible to stop all medication and just put the patient on prazosin. So coming to screening protocol, correcting the hypokalemia is very, very important, because if we do not correct, the patient will have a false negative test. And also it's important that tell the patient to take normal salt intake and not to restrict salt intake, because it can also cause a false negative aldosterone renin ratio. Ideally, drugs which markedly affect aldosterone renin ratio, like mineralocorticoid receptor antagonists, they should be withdrawn for 4 weeks. Rest drugs can be continued, and if the patient is having borderline results, in that scenario, other drugs can also be withdrawn, and if possible, the patient to be put on prazosin. Now, there are also certain conditions which have to be taken care of, like fasting is not required, but it is preferred, and to collect morning sample, and the patient has been relaxed, sitting and seated for 5 to 15 minutes. It's important not to take the sample, not to cause hemolysis. And it is also important not to put the sample on ice, as this will increase the renin levels. So the ARR cutoff, when we talk about in terms of PRA, the ratio which is commonly used is 30, although 20 cutoff can also be used. And when we talk in terms of DRC units, the newer assays, they are using direct renin concentration instead of PRA. In that, we can use a cutoff of 2.5. Now, what are the international guidelines? The Endocrine Society Guideline 2016, they have mentioned different cutoffs, as I showed on the previous slide. And confirmatory tests can be obviated in certain conditions. However, in Japanese Endocrine Society guidelines, they have told that confirmatory tests should be done in all patients. How the confirmatory test is done? At our institute, we use saline fusion test. In that, patient stayed in the recumbent position for at least 1 hour before and during the infusion of saline for 4 hours. And normal subjects will have a plasma aldosterone concentration less than 5. More than 10 is clearly positive, and 5 to 10 is the borderline case. A modified version of this has also been published in JCM, in which the patient this test is done in seated position instead of recumbent position, and in that the cutoff is 6 nanogram per deciliter. Now, why should we do subtyping into unilateral and bilateral? Once we screen the patient is positive, then why not we just start on spironolactone? So the cardiometabolic outcomes, they have been studied, and it was found that in this study published in Lancet, 602 eligible patients with primary aldosteronism treated with MR antagonist and age match essential hypertension from the registry. Incidence of cardiovascular events was higher in patients on MR antagonist than in patients with essential hypertension. So despite giving MR antagonists, we are not able to achieve improved cardiovascular outcome, because we might not be giving the appropriate dose. And if the patient is having clearly adenoma on CT scan, it is better to undergo adenectomy and remove the source of aldosterone axis. So it is important, very important, to titrate the MR antagonist therapy to raise renin, to mitigate the excess cardiovascular risk. Because what we might be doing is that we might not be giving the appropriate dose of MR antagonist. Now, coming to adrenal venous sampling. Adrenal venous sampling is performed to assess whether autonomous hormone production is unilateral or bilateral. The problem is that whatever we are seeing in CT, we have to see that whether it is producing aldosterone or not. And whether this secretion, this is unilateral or bilateral. And it's important that patients having unilateral secretion be offered adrenalectomy. Now coming to our AIMS Institute protocol of adrenal venous sampling. So we started with synactin infusion 30 minutes before the procedure, and we continued this synactin infusion throughout the procedure. The sample is collected for cortisol and aldosterone in the order of right adrenal vein, then IVC, then left adrenal vein, then IVC. The patient has to be monitored for 24 hours to see any possibility of adrenal hemorrhage. Now, these are the indices how to interpret the adrenal venous sampling. The selectivity index, it tells that we have reached adrenal vein and the sample is not taken from anywhere. So for that, we take the cortisol value. So test is interpretable only if we are having a selectivity index of more than 5. Then the lateralization index tells that whether the secretion is unilateral or bilateral. Lateralization index should be more than 4 for unilateral primary aldosteronism. Now, coming back to our patient, that 61-year-old male who had hypokalemia and multiple episodes of accelerated hypertension. Now, when this patient came next day, his blood pressure was 180 by 96. He consulted a private practitioner who started him on amlodipine, telmisartan, chlorthalidone. Blood pressure remained poorly controlled, potassium remained low. Then it was realized he's getting a diuretic. It was changed to metoprolol, but and also he was also started on spironolactone when he came to us. His blood pressure improved, but it remained poorly controlled. And then when he came to us, spironolactone was stopped for 4 weeks and the tests were done. So aldosterone is 46.4. When the initial slide I showed, the cutoffs were 15 or 10. Renin, we did direct renin concentration, it was suppressed, and ARR came to be 29. 2.5 is the cutoff. And in terms of DRC units, this 2.5 corresponds to 30. So this ARR is way too high. And the patient is also having spontaneous hypokalemia. Although because it was a part of protocol, we did saline fusion test, although it can be skipped in this patient. And post-saline aldosterone came to be 27.5. 5 is the cutoff, as I have showed in my previous slide. And CT scan done suggestive of clear adenoma. However, the left adrenal was also mildly thickened. Given the age of the patient and also the left adrenal abnormality, the patient underwent adrenal venous sampling. So these are the results of his aldosterone adrenal venous sampling. The right adrenal shows 48,500 nanogram per deciliter aldosterone concentration. So first of all, for interpreting, we have to see the selectivity index. So we have achieved clearly cannulation because selectivity index has to be more than 5. We have achieved both sides, right side 21, left side 19. The lateralization index is 131, which has to be more than 4 to say that patient is having a unilateral access. The contralateral ratio less than 0.09. So this patient is a clear case of unilateral adenoma. He underwent laparoscopic right adenylectomy, and the patient is in clinical and biochemical remission. Now coming to our patient 2, 52-year-old female who had multiple episodes of accelerated hypertension, and she did not have any documented hypokalemia. So her screening test, again, positive, aldosterone 30.6. Again, the cutoff 10, more than 10 is significant. She is having 30 aldosterone, renin concentration 1.3, ARR to 23.5. We have cutoff 2.5. More than 2.5 is positive. So in DRC units, it's coming to be 23.5. We did saline infusion test. The saline infusion is 12.5. More than 5 is positive. Now here also CT scan, it is showing left adrenal myelolipoma 1.8 centimeter. Given the age of the patient, it's myelolipoma, it's not clear adenoma. We did adrenal venous sampling. In this patient also, we achieved cannulation. You can see the right side 23, left side 26. More than 5, it's that selectivity index has been achieved. Now the lateralization index is 2.1. In our previous patient was 130. So this patient is a clear case of bilateral access. We started her on spironolactone, doses increase in follow-up, all her other anti-hyper medicines, they were withdrawn gradually and she is doing well. So when the initial question I asked what to do next in a patient who is having hypertension, hypokalemia, so we normalize serum potassium and we test for aldosterone and renin. So this is from a very wonderful review by Dr. Anand Vaidya group from Howard, and they have discussed how to approach a patient suspected of primary aldosteronism. So essential indication: resistant hypertension, severe hypertension, hypertension with an adrenal mass or any hypokalemia, that has to be screened. And expanded indication is any stage 2 hypertension. That is an expanded indication which can be further expanded to all hypertensives. So we measure plasma renin and aldosterone. So instead of seeing the ratio, it would be better if we just first focus on individual values and we see that if renin is suppressed, then we see the aldosterone. If aldosterone is more than 15, it is overtly positive screen. So 15 is it's quite high. If the patient is having potassium less than 3.5, it is overt primary aldosteronism confirmed. We can repeat and we can straight away move to next step. If it is 5 to 15, still it is a positive screen. And if possible, we can the interfering medication we can stop, we can repeat the screen. But in this case also mild primary aldosteronism is likely. If renin is not suppressed, in that case, primary aldosteronism is unlikely. So after positive screen, there is option of imaging and adrenal venous sampling to determine the potential for curative adrenalectomy. And if the patient does not have access to AVS, there is the option of starting on MR antagonist therapy at this point of time also. When the patient is having confirmed primary aldosteronism, if the unilateral disease confirmed by AVS, the patient has to undergo curative unilateral adrenalectomy and then in follow-up has to be evaluated for biochemical and clinical cure. And if the patient is having bilateral disease confirmed by AVS, then if the is not having grossly asymmetric disease, in that case also, if the patient is having grossly asymmetric disease, there is an option of non-curative unilateral adrenalectomy to attenuate the disease burden, because I have previously discussed that aldosterone excess has to be removed. So ideal way of removing the excess is removing the burden, removing the adrenal. But if the patient is well controlled on MR antagonists, we have also to titrate it on the renin values. Renin has to be raised in follow-up to mitigate the excess risk of primary aldosteronism. So normalization of BP, normalization of serum potassium, and increase in renin. These are our targets in follow-up. What is the suboptimal MRA therapy? Despite giving MRA dosing, patient is having persistent hypokalemia, increased blood pressure, suppressed renin, and CKD, resulting in hyperkalemia. So with primary aldosteronism, I would just like to say that we are not addressing even the tip of the iceberg. Thank you.
Thank you, Dr. Sara, for the excellent presentation where you took us through the whole spectrum of how to suspect, when to suspect, and how to diagnose primary hyperaldosteronism. We'll go towards the panel discussion. We'll invite all the panelists, Professor Ved Gosain, Dr. Rajat Gupta, to join us in taking up the questions. We'll discuss some of these aspects and take their experiences on this. So I would like to request all the participants, also the audience, also to put in their questions. If they have any questions, they put it in the question answer box. We'll take up the questions. We will first take the views of the panelists on certain aspects, and then open up for the other questions from the panel, from the audience. So I would like to start the discussion by asking Professor Ved Gotsain about his experience on the prevalence of hyperaldosteronism. How common is it in his experience? How common did he find it to be? And so that's very important, because we are realizing that it's a very common disorder, a very common cause of secondary hypertension as compared to all the other causes of secondary hypertension. It's very common. So and the fact that even though it's very common, it's very poorly, we don't screen for it very often. So let's understand from Dr. Ved Gosain take his what his experience is in this area.
Thank you, Rakesh. So let me first of all congratulate Sarah for a wonderful presentation. She covered A to Z, every aspect that she could have covered. And the prevalence of primary aldosteronism depends who you talk to. So let me take you back to the history a little bit, because I have had the privilege of being in Michigan, and you recall that the syndrome, which is also known as Kahn syndrome, was described by Professor Jerry Kahn from University of Michigan, which is only 60 miles away from me. And then there was a landmark article in JAMA in 1964, which was authored by Dr. Kahn and Dr. David Ravner. Dr. Ravner moved from Michigan, University of Michigan, and he became my partner, and we were together for about 25 years. And he would tell me the initial stories about how they discovered this syndrome. The first patient you might recall was a 34-year-old woman who presented with hypertension, hypokalemia, and a lot of muscular weakness, which suggested maybe hypokalemic periodic paralysis. And the landmark article established that the renin had to be suppressed for making a diagnosis of primary aldosteronism. So the controversy began almost as soon as the syndrome began. The prevalence was very high in Ann Arbor. And when I say high, it meant about 8 to 10%. And it was very low in other situations like New York or Dallas, Texas. And it really depends on, if you look for it, you're going to find it. And also the referral bias. I can recall when I was a fellow way back when, we made a diagnosis of primary aldosteronism, and we were very happy. And we said, okay, you need to go through the adrenal venous sampling so we can decide which way to go. And she said, wasn't this syndrome described in Ann Arbor? And I said, yes. She said, I'm going to Ann Arbor for my treatment. So people from all over the country ended up in Ann Arbor, which might be partly explanation of the prevalence being high. So it depends. If you look for prevalence in people who have very high blood pressure, very resistant hypertension, you may find levels as much as 12 to 20%. And I was surprised to find out, which I don't think is very commonly known, that if you select people who have obstructive sleep apnea and hypertension, the prevalence can be as high as 30%. I don't know if I should use the word depressing fact, but the depressing situation is that people are not screening it. And I was going to suggest to Dr. Alam, who did the study in Institute and found a very high prevalence. I'm assuming that was the endocrinology clinic, Dr. Alam. And I wonder if we did some studies in people who are doing primary care, how often do they screen? I guess very few. So part of the reason is that the screening is so limited is, as she also pointed out, that we probably haven't conveyed it to the primary care physicians and even to some endocrinologists that the screening should be done. And I think I agree with the Japanese Endocrine Society, and also now the modified, the Endocrine Society has not quite come up to say that all patients should be screened. Although Dr. Bill Young has recently said that. And again, history, Dr. Bill Young was a student at Michigan State University when I was a faculty. He's of course a lot more famous than I am. And in his recent address to the Endocrine Society, that he said that probably best to screen everybody. And that's mainly because people are not following guidelines. And that reminds me, life has come back full circle. When I was a resident or a fellow, we screened every patient with hypertension for pheochromocytoma and hypokalemia. We were not doing aldosterone screening, but hypokalemia at that time was thought to be a screen for primary aldo. So coming back full time, I would suggest that if we screen everybody with hypertension at least once to look for primary aldosteronism, I think we'll do ourselves and our patients a great deal of service. So thank you.
Thank you, Dr. Gosen, for making it very clear that we need to screen more and more and look for primary hyperaldosteronism more and more. At least everybody should be screened once in lifetime, as Dr. Sara also reinforced that it remains an underdiagnosed condition, and by treating it appropriately, a lot of cardiovascular morbidity and mortality can be prevented. Now, Dr. Rajat, if I may ask you, so Dr. Sara has more or less described all the clinical situations, or rather all the criteria. So how do you convince your patient that you need to be screened? So when should we, so what are the other clinical situations other than, which is part of the 3-4 points which are there in the guidelines, where you would like, you can convey to your patient that okay, this is the reason you need to get screened. So how we can do that, and how we can expand the process of screening?
Yeah, good evening, everyone. So it has been already discussed in detail by Dr. Sara and Dr. Gosai as well, that ideally everyone can be evaluated for primary eldo. But yes, the patient, those who have resistant hypertension, those who are on multiple drugs, 3 drugs or 4 drugs, still having hypertension, and especially the patients who have a family history of cardiovascular disease in a younger age, those patients probably we would stress more to screen, and they probably would agree also that if you have someone in our OPD having resistant hypertension, uncontrolled hypertension, then to explain to the patient that this is not getting controlled, there might be something else which we are missing. Probably so. I think the resistant hypertension, say more than 150, 100, or patient who has been on 3 drugs or more and still uncontrolled, probably would be we would be able to convince them to get them tested. Yeah, it's a costly screening and not available everywhere. Even the proper testing is not available in many labs, but still probably those group of patients, and if they happen to have some sort of cardiovascular disease or something like already developing some sort of chronic kidney disease, then obviously they would again be more likely to agree to screen for possible reason for uncontrolled hypertension as well as for underlying cardiovascular disease. Uh, those who have normal hypertension, means not uncontrolled, probably it would be difficult to convince them. Or I think the resistant one, we should be able to convince.
Thank you, Dr. Rajat, for the very beautifully underlining the fact that who needs to be screened. Because although we know that everybody should be screened, I mean, once in their lifetime, but we should probably prioritize those who are likely to give us, I mean, who are likely to be more likely to have this problem, and probably think of the screening everybody at least once in their lifetime. So coming to this issue of screening events, once you decide to screen a particular person, what should be the precautions before collecting the samples for renin and aldosterone for a screening test? Dr.
Thank
Sarab.
you, sir, for the question. Most important thing is to check the medication protocol, and if the patient is already on mineralocorticoid receptor antagonist, it is prudent to discontinue that for 4 weeks, and also to correct hypertension hypokalemia, potassium should be more than the aldosterone and renin. And if the borderline results are there, then we can discontinue other interfering. It's important to collect the sample in the morning, when the patient is sitting for 5 to 15 minutes, and we ask the patient not to restrict salt intake. The salt intake should be normal before taking the sample, and not to cause hemolysis during the sample, and the sample should not be transported on ice. These are the important precautions we need to before taking the sample for renin and aldosterone.
Thank you, Dr. Sarah. So these are the practical aspects of collecting samples for aldosterone and renin. So, sir, we do understand that there is a need to expand the scope of screening to primary care level. So it should not be a test which should remain only limited to endocrinologists or specialized experts. So we do understand there is a need. The screening should be expanded. So what is the practical way to confirm primary hyperaldosteronism? So most of the tests are usually complicated. So what is your approach to next step once we have a positive screen? Dr. Gosen, Dr. Gosen, would you like to respond to that question?
Yes, sorry, I had to step out for a minute.
Okay.
So what's the practical way of confirming primary hyperaldosteronism? You know, there are several tests that are talked about, captopril test and use of fludrohydrocortisone and the saline infusion and then salt loading. So out of all these 4 tests, the one that I have used and I have the most experience with is the saline infusion test. It's relatively simple. You bring the patient to your clinic, at least that's what we used to do in the outpatient. Have them lie recumbent for an hour or so, and then give them 2 liters of infusion of saline over 4 hours and measure the plasma aldosterone before and after. If it's not suppressed, it confirms that the patient has primary hyperaldosteronism. Lately, I think Sarah actually referred to it, the seated saline infusion test. It is supposed to give you more sensitivity. And I looked at the recent paper of 2018 by a group of people who were doing this test, comparing the seated saline infusion versus the recumbent saline infusion. And they claim that the sensitivity of the seated test was better. What's bothersome is that in their study, the sensitivity of the recumbent saline infusion was only 38%. So that makes me wonder as to what was going on. But in general, if you look at the sensitivity and specificity of the saline infusion test or recumbent, it's all in the 80 to 90% range. So it's a pretty good test. Some people have suggested that you do more than one test, but I think most experts actually believe that the screening was positive and you do one of these tests and that confirms the diagnosis, and that's usually sufficient. And then you go to the next step of the adrenal sampling. So my answer to that question is based on my experience, saline infusion test. I have not done the seated infusion test, and if any of you have done that, I would like to hear from you. But it may be that the seated one is more sensitive, but I think we need more studies and we need more experience with the seated saline infusion test and then compare it to the recumbent one.
Thank you, sir, for sharing your experience on the saline loading test. I would like to ask Dr. Rajat about, what could be the possible differential diagnosis? Could there be anything else that could be there if you have a positive test?
Uh, so positive test means high aldo and low PRA suppressed. PRA probably would suggest primary aldo. Then there would be subtype analysis. That's a different thing that we will do with CT or ABS. But there are certain conditions which might mimic a person coming with hypertension and hypokalemia. Then one is those is other mineralocorticoids acting on the receptors other than aldosterone. So it may be deoxycorticosterone, as we find in 11 beta hydroxylase deficiency, though uncommon, or 17 alpha. These disorders usually present in childhood, but if they have partial enzyme deficiency, then they may present in adulthood also. And then another is Cushing syndrome, especially the ectopic one, which may not have Cushingoid features. So that also can mimic a person coming with hypertension and hypokalemia, like primary aldosteronism. And third, another rare disease is cortisol resistance, primary cortisol resistance, in which we have glucocorticoid receptor resistance to cortisol, and then it acts on mineralocorticoid receptors and then lead to hyper mineralocorticoid state. And similarly, licorice ingestion we have seen, and there are few publications also, excessive intake of licorice, which blocks 11 beta hydroxysteroid dehydrogenase 2. And another thing which I think is renovascular hypertension, renal stenosis. Again, that would be having high renin and high aldosterone, and then ultimately leading on to hypertension and hypokalemia. So this is also an important thing, renal stenosis, to exclude, obviously not with aldo-PRA ratio more than 20, but the patient who is coming with hypertension and hypokalemia, then screen would not show like we see in primary aldo, but it would suggest high aldosterone and high renin because of renal stenosis. It will be have high renin, and then secondly leading to high aldosteronism, and then consequently hypertension and hypokalemia. So these are a few things which I keep in mind if we see a patient of hypertension with hypokalemia other than primary aldosteronism.
Thank you, Dr. Rajat, for raising a very important issue that there are some differentials. Dr. Gosen, would you like to add anything to that? Anything to that list?
No, I think he covered it very well, but I'm curious as to what's the Indian equivalent of licorice. I had never heard of the word licorice until after I came to the United States. And again, my former partner, Dr. David Ravner, he was one of the few first people who described licorice ingestion
It's
as one of
Maleti,
the
sir. Maleti.
Maleti?
Yeah, it's in many Ayurvedic preparations. Even though I have seen this as a part of few drugs prescribed for corona. I've seen many Ayurvedic preparations being described for COVID-19, and they happen to have this malati or licorice.
Okay.
And incidentally, patient also had hypertension.
I don't know about corona in India. I think from what we hear, which is probably third-hand information, almost anything can be prescribed for corona, whether it works or not. So back in India anyway.
So I think there is, thank you, Dr. Gosen, for that. So there is something which I recently came across while I was reviewing, going through fungus and endocrinology. So the posaconazole can also actually block some of the adrenal enzymes, and it has been described to cause pseudo hyperaldosteronism. The same picture, but so that is something which is because there is also an epidemic of mucormycosis in India, and many of the patients are getting posaconazole. So if somebody develops hypertension and hypokalemia, you also need to be careful on that also. So
and patients are going to be on posaconazole for a long duration of time now.
Right. So my next question
so more business for endocrinologists.
So my next question to Dr. Sarah will be, so you already mentioned that so these patients have a very high burden of cardiovascular disease. They're predisposed to develop cardiac problem, early stroke. So do we have a more strict screening policy for evaluation of cardiovascular disease in this patient? So how do we go about preventing the complications? So there might be patients of say hyperplasia who have this, who need to be on long term spironolactone. So how do we monitor these patients?
So, sir, there have been several meta-analyses and studies to show that there is a very high burden of cardiovascular disease in patients with primary aldosteronism. In a study published in Hypertension 2018 by Japanese primary aldosteronism study, JPAS, they are doing a lot of work on primary aldosteronism, and they have shown that patients who are having hypokalemia and high aldosterone value baseline, they have given a cutoff of 12.5 nanogram per deciliter. Such patients, they are more likely to have cardiovascular disease, and if possible, wherever possible, if we are able to localize and remove the aldosterone excess source, that is a way of preventing. Other than that, we have to follow and raise the renin. Renin should not remain suppressed. That is, PRA should not remain less than 1 in patients who are on mineralocorticoid receptor antagonists. Blood pressure should be controlled, and it is also important to have normalization of potassium, and routine screening by echocardiography should also be done to look for LVH. So these are the routine precautions we should do, as the such patients of primary aldosteronism are found to have a high burden of cardiovascular disease.
Dr. Gosen, would you like to add anything to it? Your follow-up policy for patients who are on long-term mineralocorticoids because of primary hyperaldosteronism?
I think she's covered it well, but the question that pops in my mind, about 20% of patients with hypertension, particularly amongst blacks in the US, have low renin. And it's lower than normal, although it's not completely suppressed. And there was big controversy in the 70s and 80s whether the renal levels were in and of itself a contributing factor for the cardiovascular disease. And my memory is that it was John Lara's group that was actually blaming the higher levels of renin, not the lower levels of renin, which were contributing to the cardiovascular disease. And the other question is, which I think Sarah alluded to, is when you treat patients with mineralocorticoid antagonists, you normalize the blood pressure most of the time, but you don't normalize everything else, which may be contributing to the residual, if you will, cardiovascular complications. And so as I was thinking about that, a question popped up in my mind that patients who have primary aldosteronism due to an adenoma, and that's taken out, the blood pressure returns to normal, most of the biochemical parameters return to normal, and we assume that their cardiovascular mortality is, quote, normalized. But I don't know, and maybe Sarah has reviewed the literature much more extensively recently than I have. Do you know if we follow the patients who have had adrenalectomy and, and by definition are cured, if their progress in terms of cardiovascular morbidity and mortality is same as people without hypertension? I have not come across any study, at least not that I can think of, but maybe you have.
So there have been several studies, and they have found that the risk comes back to normal as when the patients are followed up, and when they have removed the aldosterone excess. But that also depends upon the duration of already established primary aldosteronism. I mean, when was this surgery done? That is also an factor.
And I think the other thing is this, that 30%,
later to you.
30% or so patients, even after their adrenalectomy, don't become normotensive. And then the question becomes whether they had essential hypertension,
yes,
and then on top of it, they had primary aldosteronism. So that's why I asked that people who have adrenalectomy and their blood pressures are normalized, we have assumed, I think, but I don't know of any studies that have followed these people for 10 or 20 years and said their cardiovascular morbidity and mortality is the same as people who don't have it.
So another point that I just wanted to ask you is that we were speaking of aldosterone being harmful, aldosterone being causing the problem. So on follow-up, why are we looking at the renin? Why not the aldosterone levels to decide the optimal treatment?
I think it may be the combination of renin and aldo, that's both. But with the mineralocorticoid antagonist, we have essentially negated the effects of aldosterone, although the levels may still be high. And then the question about the renin, and like I said, in the earlier studies, it was the higher renin which was being blamed for cardiovascular complications. And now, as Dr. Allen pointed out, that when you treat people with mineralocorticoid antagonists, you want to make sure that their renin comes out. So I think it's something that needs to be explored even more.
Sir, I would like to add here that if the patient is on mineralocorticoid receptor antagonist, the aldosterone will remain high, but renin is a surrogate marker of aldosterone access in patients on mineralocorticoid receptor antagonist therapy. But patients who have undergone adrenalectomy, in that the absolute aldosterone levels are what we see and follow up. So that is how we do. If the patient is already on mineralocorticoid receptor antagonist, then the aldosterone levels are not reliable to see whether the patients will remain having high aldosterone levels.
Thank you for the clarification, Dr. Sarah. Uh, I would like to ask Professor Ved Gosain about his experience with the AVS, because this is a major limiting factor in many centers. We are not able to do the AVS. So, how do we go about with that?
Well, this is an embarrassingly simple question for me to answer. And the reason it's embarrassing, so let me answer the question first, is yes. I think, except with the exception, if you have a very young patient and the aldosterone renin ratio have been distinctly abnormal and there's hypokalemia, and then you do a CT and there's clearly an adenoma on one side and the other adrenal looks okay. With very few exceptions in young people, I think we can skip. But in almost all other patients, we have to lateralize because removing a single adenoma is curative. And if it's bilateral, then we don't have a surgical option. We then have to go to the medical option. And the reason it's embarrassingly simple for me is because when we had patients that needed adrenal venous sampling, and then we would tell them if we find an adenoma, we'll remove it. And then many of them preferred, actually, I would say most of them preferred to go to Ann Arbor. And at least in the initial phases of my association with Dr. Ravner, we knew the surgeons in Ann Arbor much better than our own local surgeon in terms of the removals. So I have very little direct data to share with you from Michigan State University, but of course there's a lot more in Ann Arbor from the University of Michigan. And it's clearly a difficult procedure. You need to have a radiologist that's well trained, and they can catheterize both adrenal veins, and then the sensitivity, as Sarah pointed out, you need to do the cortisols. And then there are people who do it with ACTH stimulation or without. But I think those are mainly technical details. Most important is you need a radiologist that can catheterize and get you the appropriate samples. And if it's clearly lateralizing, then a good surgeon. And again, I have lived through the days of open adrenalectomy, and now, of course, almost everybody is getting a laparoscopic adrenalectomy.
Thank you, Professor Gosain. So, Dr. Sarah, you have been part of the adrenal venous sampling program in All India Institute of Medical Sciences. So, what is your experience with that?
When we started with the procedure, because it was not being done previously, it started in 2017 only. The adrenal venous sampling, we faced a lot of initial teething problems, and the initial cases we were either not able to cannulate the right adrenal vein, the cortisol ratios were not achieved. But after doing initial few procedures, now we are having almost 100% rate of successful cannulation. It's very important to achieve selectivity index in both the adrenal veins to interpret the results adequately.
So, Sarah, you're practicing now in Faridabad. Let's say you have a patient are you doing adrenal sampling in Faridabad itself, or would you refer them to the AIMS?
Sir, actually, I have only recently started practicing, and I have screened few patients, but because of this COVID outbreak, they have not yet been able to come for follow-up. I am planning to do. We have one interventional radiologist with us who has been trained from Korea, and he has done case of adrenal venous sampling there. So we plan to do it.
So my question is, if you were to send a patient to AIMS, would the radiologist or interventional radiologist look at your recommendations and go ahead and perform the procedure, or would you have to go through some more elaborate
So it has
consultation with
done through
endocrinology and all that?
endocrinology department first. They will not do. Yes, sir. They will not do directly. They'll have to go through the endocrinology department first.
That is sort of the difference that I thought unfortunately still persists. You are a DM from AIMS. You're sending them a patient who needs the adrenal venous sampling. They should take your word for it and do it for you. But I'm way out here, so it doesn't matter.
So thank you both Professor Gosen and Dr. Sara. So Dr. Rajat, a very important part still remains medical therapy. So there are cases which are bilateral, and and they need to be on uh, medications for a very long time. So would you like to elaborate on which agents are the preferred ones, how to start, how to continue, how to monitor, what are the possible side effects? So these are important information which all the treating physicians and primary care physicians should be knowing.
Yeah. So as AVS is not available in many places, and we may not localize proper adenoma, and means it may not be a direct case for adenectomy for many patients, then obviously medical therapy remains. And even if patient doesn't choose for surgery, then medical therapy remains. And the preferred drug is obviously mineralocorticoid receptor antagonist. And spironolactone has been the preferred drug. It is more efficacious than eplerenone, which is also being used. The important thing is we start with spironolactone and then start with a lesser dose and gradually build it up. The key factor has already been elaborated by Dr. Sara, that patient blood pressure should be controlled, then patient potassium, as is being mentioned now, it should be not normal, it should be high normal. So it should be kept high normal, and then if PRA can also be followed up. But they have been, this was one case, actually one series in which authors had said that once PRA is less than 1, then probably they don't have excessive cardiovascular morbidity or mortality. But otherwise, there is also some debate that many patients may be having coexisting low plasma renin hypertension, low renin hypertension. So it may be difficult to follow with the renin value in those patients. So high normal serum potassium is also being advocated as good as doing plasma renin activity on the lower side. And then if we start with the spironolactone, then obviously the concern is one is worsening of renal function, which because patient might be having a background, some sort of kidney disease because of long-standing hyperaldosteronism. And then once we block aldosterone, there would be some worsening of renal functions. So that should be expected and told to the patient in advance. And then at times hyperkalemia happens. Then we need to retract on spironolactone and decrease the dose of spironolactone and add some other agent. In addition to that, patient might be having other symptoms like painful gynecomastia, or female might have mastrodynia. So in those patients also we need to cut down on those. Menstrual irregularities can happen. Then eplerenone can be substituted because it doesn't block receptors of, it doesn't block androgen receptors, but it is less efficacious. And then once it is being said that once you achieve say high normal potassium and good control, then gradually again we can reduce the dose of spironolactone, and maybe patient settles down on a lesser dose later on. And at the same time you control the blood pressure as well as keep potassium in the high normal range. But worsening of renal function is definitely there. At the same time, we would look for other cardiovascular factor, like Dr. Sarah had said, echocardiography, or sometimes patient get rhythm disturbances. Then also look for diabetes, because many patients of primary eldo have coexisting diabetes. And it is also one concept which I would like to ask after I finish this question. Coexisting cortisol hypersecretion, whether we should evaluate for any case of primary eldo having aldosterone producing adenoma. So other than that, other drugs can be used, but the most likely, most relevant is melanocorticoid receptor blocker with MRA, and then follow it up with potassium kidney function, which may need to be done maybe a week or every week or every 2 weeks for initial 6 to 8 weeks, and then followed it up later on.
Thank you, Rajat, for clarifying these issues. I would like to ask Sarah about the confusion with renal failure, CKD stage 3 and above. There are a lot of questions in the question box from many of our participants who want to know how this can impact the diagnosis, and also in terms of the management and various issues. Dr. Sarah?
Thank you, sir. First of all, Dr. Rajat sir has raised a very important point that there is a coexistence of cortisol co-secretion, which has been described. In fact, the entity has been labeled as Cushing syndrome, Cushing and Con. And in our protocol, in AIMS, we used to screen every patient who had adrenal mass, even positive screen for primary aldosteronism for cortisol axis. We did that, and so that is one thing. And many case reports are also there on that of coexistence of cortisol secretion. Now, coming to the question, how do we follow the patients after surgery for adrenal adenoma, and how to interpret results in patients who are having CKD? Very interesting study published in Lancet Diabetes Endocrinology 2018 by T.A. Williams Group, and the study is named as PASO study. And to follow the patients with adrenal adenoma, we have to see the clinical success and the biochemical success. So they have defined it as complete clinical success, partial clinical success, and absent clinical success. So complete clinical success is normal blood pressure without the aid of antihypertensive medication. Partial clinical success is the same blood pressure before surgery with a less daily defined dose, and absence is unchanged. The blood pressure cutoff they have used is 140/90 for clinic and 135/85 for home blood pressure. Also, to define the complete biochemical success is post-op aldosterone less than 5 nanogram per deciliter, and if the patient is having more than 5 nanogram per deciliter, we should do saline suppression test and demonstrate aldosterone level less than 5, and outcome assessment should be first done in the 3 months post surgery, but final outcome should be assessed at 6 to 12 months, as many patients are shown to be, as the CKD is it can be an outcome directly of primary aldosteronism. So if the patient is having CKD 4 and 5, it is very difficult to interpret the results, because CKD itself can cause false positive aldosterone renin ratio. Up till CKD 3, we can interpret with the similar values, but we can check also, like the patient is having hypokalemia in the face of CKD. That is one pointer patient might be having primary aldosteronism. And if the patient is having CKD or heart failure, then it is difficult to do saline infusion test in some patients. And if there are chances of fluid overload, then we should avoid saline infusion test. There are other options like fludrocortisone suppression test, which can be done in such patients. And although at our institute we have not used that, but it is like a fairly well described test. And maybe Dr. Gosain sir, you can share your experience. If you have used, I have not used that in my patient's fludrocortisone suppression test, but that is an option in such. It is difficult to do saline infusion test if the patient is already in a case of volume overload.
It's a matter of semantics, Sarah. I have personally not done the fludrocortisone stimulation test, suppression test in anybody actually. It's because 4 days of the administration and you don't know whether the patient will take it or not take it. But if we think about it, if the patient is fluid overloaded and you're giving fludrocortisone, they're going to hang on to more fluid anyway. But it may not be as much as 2 liters over 4 hours, but if you give it for 4 days, they may easily accumulate a positive balance of 2 liters. So in a long-winded way, I don't know the answer. So I think under those circumstances, I don't know, maybe the captopril suppression test might be a better option. But again, having said that, I've not done it personally.
Dr. Sara, there are lots of questions and we only have another 5-7 minutes left. So do you have faced any complication? Question from Dr. Amit. Do you have faced any complications during performing AVS? Any issues related, any problems which have come up?
Sir, in one patient out of 30 adrenal sampling procedure performed had an episode of hypertension, which was resolved with the fluids, given fluids. Other than that, none of our patients had any complication.
Dr. Rakesh, would you like to ask any of the questions which are there in that chat box? Anything you feel is important or anything from your side?
Yeah, I think major questions that people have been asking is about the interpretation of CKD, which Sarah has just alluded to. And I think then the other one was about the AVS.
So
all the other things we have covered in the discussion that we have taken up.
So any comment on glucocorticoid, the genetic varieties of hyperaldosteronism, young stroke in them? So is how frequently do we see it, or it's just a very rare genetic entity? So, Dr. Gosen, if you...
I think it's a fairly rare entity. And of course, the genetic testing is sort of a more recent advance in medicine, if you will. So I think if we do more genetic testing, we might find it. But I think the glucocorticoid responsive aldosteronism, I think I've seen one in the last 30 some odd years. And like I said, technically, although I wasn't the expert, my partner was the expert of the primary aldosteronism, and even with his experience and mine together, we saw one patient that had the glucocorticoid responsive aldosteronism. So it's got to be rare, but since we're doing more genetic testing, my guess is we'll probably find more.
So I think I would like to thank Professor Gosen and Dr. Rajat for their wonderful inputs, and congratulate Dr. Sara for an excellent presentation. I would now invite Dr. Rakesh to just for the concluding remarks and hand over back to the organizing team after that.
So I think everybody would agree that we had a brilliant presentation from Dr. Sara, and Dr. Ved Gosen gave his pearls of wisdom in this area with his vast experience that he has. Dr. Rajat also added to the added with his experience that he has been dealing with in the last several years. So I think we had a very interesting session. I'm sure all the participants have really benefited by attending this session, and we all thank Samarth Pharma for giving us this opportunity to be here today. Over to Mr. Prashant.
Yes, yes. I'm sure, sir, that our esteemed panelists and delegates will agree that There is a dearth of long-term clinical data outlining the diagnosis, screening, treatment modalities with subjective health outcomes, as well as the comparative studies with respect to different drugs used in management of adrenal disorders. Owing to these challenges, more emphasis and importance is inclined towards the clinical acumen of treating physician, often the primary care provider, as highlighted by Dr. Alam as well as Dr. Ved. Hence, it is imperative that there should be more and continual experience sharing among the medical community with respect to the diagnosis and treatment of these disorders. This is precisely the reason we started this initiative in 2020 under the banner of EPIC. And I would like to offer our heartfelt thanks to our national conveners, Dr. Rakesh Sahai, Dr. Sanjay Kalra, and Dr. Ganpati for their help, guidance, and support in helping us organize this series of webinar under the banner of EPIC. With today's webinar, we have completed close to 9 webinars on adrenal medicine. A big thank you to all of you from Samarth Life Sciences family, makers of Hyzone, that is hydrocortisone, and fludrocortisone, that is Floricort. And you can find these webinars on our YouTube channel known as DocHead. Stay safe, stay healthy. Thank you, everyone.